Now that we have discussed first-degree heart block in detail, let's now delve into second-degree heart block, beginning first with Mobitz 1 or Wenckebach, followed by Mobitz 2. Most commonly, our patients with Mobitz 1 or Wenckebach second-degree heart block are going to be asymptomatic. However, they may also present in the context of myocardial ischemia. Additionally, medications which slow down conduction at the AV node, including beta blockers, calcium channel blockers, and digoxin, may also tip off a patient into Mobitz type 1. The pathophysiology in the case of Mobitz 1 is most commonly going to be at the AV node. This can be triggered by ischemia of the right coronary artery, as the right coronary artery actually supplies the AV node. Additionally, as was the case for first-degree heart block, we can also see Mobitz type 1 in athletes, including runners, as they have extremely high vagal tone at baseline, and the vagus nerve is ultimately going to slow down conduction at this AV node. In Mobitz type 1 on EKG, classically this EKG is going to show progressive PR lengthening until a beat is dropped. The PR interval will then reset to its original length. These patients typically will also have a narrow QRS complex. This can be appreciated in our EKG in the center of the presentation, where if we take a look at the left-hand side here, we can see that this PR interval ultimately becomes longer when we take a look at this PR interval from here to here. Then following that PR prolongation, again shown here, as this PR interval becomes even longer, we then have a dropping of a beat before the PR interval resets to the original length that we saw earlier on in the EKG strip. Additionally, we can see that these QRS complexes are quite narrow, and all of these features are highly characteristic of Mobitz type 1 or Wenckebach. As we stated previously, the most common presentation of second-degree heart block, Mobitz type 1, is that these patients are going to be asymptomatic, and if these patients are indeed asymptomatic, then no intervention is going to be required. We can consider stopping offending medications such as beta blockers, calcium channel blockers, and digoxin. However, ultimately, Mobitz type 1 carries a very, very low risk of progression to complete heart block or third-degree heart block, and therefore no intervention is generally going to be needed in these patients. Next up, we have second-degree heart block, Mobitz type 2. These patients also most commonly will be asymptomatic. They may present in the context of myocardial ischemia, and once again, there are medications which can ultimately slow down conduction at the AV node and tip off a patient into Mobitz type 2, including beta blockers, calcium channel blockers, and digoxin. The pathophysiology in the case of Mobitz type 2 is fibrosis of the conduction system. This can be seen in patients who have a history of myocardial infarction, as death of the myocardium could ultimately lead over time to fibrosis and therefore inhibition of the conduction system. And classically, Mobitz type 2, unlike Mobitz type 1, is going to occur below the AV node. The result of this fibrosis below the AV node in our patients with Mobitz type 2 is that these patients will have unexpected dropped beats on their EKG. Additionally, in very high yield to distinguish Mobitz 2 from Mobitz type 1 or Wenckebach is that in Mobitz type 2, these patients will have no change in their PR interval. We are not going to see any of that PR prolongation that we saw in our patients with Mobitz type 1 or Wenckebach. This can be appreciated if we take a look at lead 2 at the bottom of this EKG strip, where we can see that we have this PR interval, then the same PR interval, and suddenly we have this unexpected dropped beat. We then have resumption of that same PR interval, that same PR interval again, no PR prolongation, and then once again we have this dropped beat, and this happens once again as we move along the EKG strip, and therefore these findings of having unexpected dropped beats but no change in the PR interval is highly characteristic of Mobitz type 2. And as one might expect with these unexpected drop beats, Mobitz type 2 tends to be more commonly symptomatic and has a greater risk of progression to complete heart block than Mobitz type 1. Because of this risk of progression to complete heart block, When we have a patient with Mobitz type 2, it does not matter whether the patient is symptomatic or asymptomatic, as a pacemaker is going to be indicated regardless. This can be achieved via a double lead pacemaker, as pictured here, with leads in both the right atrium and the right ventricle, or we can use a single lead pacemaker with a single lead present in the right ventricle. And therefore this distinction that in Mobitz type 1, generally we are not going to need to perform any intervention, whereas in Mobitz type 2 we are going to need to put in a pacemaker, is an extremely important distinction to keep in mind. In addition to the different EKGs between Mobitz 1 and Mobitz 2, as well as the fact that we are going to manage patients with Mobitz 2 with the use of a pacemaker regardless of symptoms, there are also some differences between these two types of second-degree heart block when it comes to their responses to exercise and atropine. Recall from your physiology that for both exercise and atropine, these are going to lead to an increase in heart rate through inhibition of vagal activity. Therefore, their overall result is going to be an increase in conduction through the AV node. Because Mobitz 1 is generally a problem with conduction through the AV node, both exercise and atropine are actually going to improve symptoms as well as EKG findings in patients with Mobitz 1. However, Mobitz type 2 involves a problem that occurs below the AV node, and therefore exercise and atropine are actually going to worsen or have no effect on Mobitz type 2. This difference between Mobitz 1 and Mobitz 2 is also reflected in how these different types of heart block respond to vagal maneuvers. As we know, vagal maneuvers increase conduction through the vagal nerve and therefore are going to lead to decreased conduction through the AV node. Vagal maneuvers include the Valsalva maneuver, as pictured here on the right-hand side of the presentation, carotid sinus massage, as well as the oculocardiac reflex. In the case of all of these vagal maneuvers, there's going to be increased conduction through the vagal nerve, and therefore this is going to lead to slowed conduction through the AV node, thus exacerbating Mobitz type 1. However, this will have the exact opposite effect on Mobitz type 2, which occurs below the AV node. And therefore, anything that leads to increased vagal activity, such as vagal maneuvers, is going to worsen Mobitz type 1. However, anything that decreases vagal activity, such as exercise or atropine, is going to improve Mobitz type 1. However, the opposite effects will be seen for Mobitz 2.